this is a case that I have just recently finished. We started about 2.5 years ago. So the treatment time has been about 2.5 years. And this was a case that came from a general dentist who actually wanted to treat this case non-extraction. And obviously the patient was an adult patient, I'd say mid-30s. And to be honest, she was actually very happy with her smile. It was just because the dentist said, go see somebody for this, that she even made the appointment with me. So when I interviewed her, the first thing she said to me was, I'm actually very happy with my smile. I love it. I love the character in it. I love the bit of crowding. So I said, oh, look, we can't just treat halfway and leave some crowding. Either we're going to fix it or we don't. So, it was about the fact that she was an easy patient to begin with who just loved her smile anyway. So it made life a bit of a dream. So obviously, if you see what we're seeing here, you see overall quite balanced vertically. She's, I would say, mesofacial. Okay, looks like she doesn't have any overbite, but that's deceptive because what she does have is bimax protrusion. You can see in the buccal shots, if you see the buccal shots, how forward her incisors are. And on top of the forwardness of the incisors, the protrusiveness of the incisors, you've got moderate crowding. Now, when you have protrusive incisors plus moderate crowding, this becomes severe crowding. So when we looked at this case, we kind of considered, and there is no class 2, so there's no scope of distalization of upper arch and things like that because she's a class 1. You see her molars are beautiful class 1. So when it's class 1, we're not going to really distalize or create space from distalization. So we have less tools to create space for her crowding. The tools that we have are extraction now. Okay, so obviously both arches have significant crowding, so it has to be premolar, 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 4 premolars to maintain the class 1. And then obviously it gives us space for retraction of incisors. So that is actually a very valid plan, and I would go for that. If patient had agreed to it, I would actually go from that from day 1. I wouldn't hesitate. What it also does as you extract premolars, it allows you greater retraction of the incisors. And as it allows you greater retraction, you close the overbite, because as teeth come back, they also vertically erupt and extrude. But when you push the teeth forward and you procline them, you open bite. So if here I didn't extract, it's very scary, right? It's really scary. Imagine putting all these teeth in alignment. What's going to happen? They're going to come forward more. They're already so forward. So if they come forward, she's going to be an open bite. Okay. But she's naturally, skeletally and facially, she's not open bite. So that would be an iatrogenic created open bite for her. Okay. So obviously bimax protrusive cases, which is very common in the African ethnicity, you kind of have to extract. A lot of African bimax protrusive cases and Asian as well, you kind of extract 4 premolars. Very common treatment to do. So we kind of really pushed towards extraction. She wasn't really keen on that. So what we decided to do is, okay, let's try, because she was so easygoing with her smile, we said, let's try some IPR and just improve it slightly. And she was even open to getting restorative and veneers if she really didn't like the orthodontic result. Just such an easygoing patient. And very lovely, and just, just accepted whatever I said. So I said, okay, let's try a little bit with IPR. You don't have obvious recession. Now, one thing is a lot of African and even Indians actually tend to have thicker biotypes of gum, whereas Caucasians tend to have thinner. So in a Caucasian bimax protrusive, I'd be more scared to do this, okay, to do non-extraction, because you're more likely to get recession. But look how forward her teeth are, yet there is no sign of gingival recession. You see a really pigmented, thick gingiva. So you kind of think, okay, it's not that I want to protrude her. Definitely you cannot protrude her any forward because there's no bone there, right? How are you going to move teeth if there's no bone? But you kind of don't even, you're not afraid if it did you know, if you did have to procline, maybe 0.1, 0.2 millimeter, because I don't think she has a high likelihood of recession. So this was really what we said. She was in her 30s at the time she came to see me. We said she was edge-to-edge bite, and edge-to-edge bite is very common with bimax protrusive cases, which she is. She's got a mild anterior crossbite too at the 1-2, and possibly due to crowding. Anterior crossbite doesn't mean it's class 3. She's got class 1 molars, so she's actually a class 1 occlusion. And it was very obvious in her Ceph as well, which I'll show you in a moment, that she's very protrusive, okay? But that is her ethnicity. She is always going to have beautiful protrusive lips. So these were her objectives. Her midlines weren't that off. So to correct her alignment, to correct her anterior crossbite, reduce her buccal corridors. Again, not too significant, just a little bit. You can see the premolars on this side are just a bit in. Reduce the bimaxillary dentoalveolar protrusion by anterior retraction. That was key. We have to bring those upper incisors back while we find space to resolve the crowding. And to bring back the teeth, we need more space. So she's severe crowding while giving her a good occlusion at the end. So all of these objectives are a little bit tricky to go non-extraction. That's her Ceph, okay? I don't have her post-treatment Ceph, by the way, because she has to get it done from another place, but I do have her pre-treatment Ceph and OPG, and I have a post-treatment OPG, which I'll show you. So that's a pre-treatment. You can see how forward that lower incisor is. I mean, damn, it's just like coming out, right? So we don't want to bring it out any forward, yet we got to tuck it back and resolve the crowding here. So we need way more space than we think. Impacted forehead, the oral surgeon advised to just leave it alone, which she has. And then she did have all her impacted upper eights removed, actually. She had a extra a fourth molar up there. So she's had all of that removed. And this is her scans when we started her. So we're looking at, you know, measurement of crowding. We're just looking at just the dental models. Here you can see a nice class 1 on both sides and a nice midline coincidence. So she's quite symmetrical, facially as well as dentally, and symmetry is good. So that means if I'm going to do IP, I'm going to try and keep everything symmetrical. So these were my original instruction to the technician, where I basically said the very first time, and we were talking 2020, I said this will be 2 years in treatment. We said expand all quadrants by 3 millimeter. Now, in an adult, we don't usually go more than 1 or 2, but in her case, looking at her gingival biotype and the fact she had no recession, I did think of let's try 3 millimeter because we decided non-extraction. Okay, a very, very difficult case to do non-extraction, completely experimental, actually, where I was going to assess the soft tissue response. And if I didn't think it was going to go well, we were going to extract. Okay, usually you make that decision within the first 6 months. So my favorite attachments, I love my horizontal 3 millimeter close to cuspal third. All my attachments tend to be there. So all the canines and all the molars, first molars and all canines, okay? Because canines had the maximum movement. If you saw, they were all ectopic. No other attachments. I want no other attachments on any other teeth. So I don't do too many attachments, actually, especially with Invisalign. With Spark, I do more. Except 1222. Now, 1222 were also very rotated, or I think they needed a bit of movement. Now I'm telling them what to do, a slight bit of intrusion of the upper molars and posteriors and extrusion of the upper anteriors. And we're doing a lot of IPR. Look at the beginning IPR, 0.5 millimeter from day 1, okay? And we're going back to the 4s here. We're not even doing 3 to 3. So we know from day 1, if we're going to go non-extraction, this is heavy IPR, okay, from day 1. So here we are. We've planned our clean check. We are basically increasing overbite with anterior extrusion and posterior intrusion. And one thing I didn't do here, actually didn't put central attachments. You know, generally when I'm extruding upper centrals, I would put attachments on them, but I'm also retracting them. So if I'm retracting them, extrusion is going to kind of happen. So it's a balance of, like, I don't like a lot of attachments, to be honest, especially at the front, but sometimes you can't avoid them. So I've got a lot of IPR here, and we look at it from the side. Again, a lot of IPR. Now, she didn't need class 2 elastic. So please don't think the class 2 elastic here was to change class 2. It was simply to bring that canine down. I could have even put a triangle there. I could have, so if you look here, if I pause, I don't think I can pause, guys. But for those who are a bit more experienced, beginners, don't get overwhelmed. But there is basically no need for class 2 elastic here. I think I just put it there in case I wanted to bring that canine down. We know the extrusion of the 1-3 is the most difficult movement here. It's very difficult. So you see what we're doing, 44 aligners. And I've always told you, don't be shy with aligners, go for it. So maybe Invisalign gave me initially 20 or 30. I said, give me 44, okay? So I want a lot of aligners. The more aligners I do in the first and second set, my refinements go beautiful. Okay, so we've got this kind of stuff. We are about 17 months in treatment. I don't know, 44 aligners are 17 months. Maybe we had another revision. We're not showing, I'm not showing you every revision, but about 17 months in treatment. And you can see the bimax protrusive is a bit less. You can see from the buccal shots on the side, incisors haven't come forward. In fact, they're retracting a little bit, okay? They're not as forward as pre-treatment, but we got lack of space, significant lack of space. We're trying to fit those canines and we're trying to actually retract those incisors a bit more. But lower crowding is resolved. We've got the lower arch quite nice now. We've got some expansion there now. And looking at this, she has no recession on the 3mm expansion I did. So now that I look at it and I go, well, we did 3mm expansion, maybe 30% didn't happen because 30% is the inaccuracy in a clean check for expansion. Perhaps we could try a bit more expansion here. She does have a nice wide smile. She does have a bit of an omega shaped arch in the upper, and we are at the limits of the bone. But again, I kind of think let's do another millimeter or so. Let's see what I told the technician. So we've got a definite lack of space. Now look at her laterals. Her upper laterals are so wide. So I've already done 0.5mm IPR, and I'm very accurate with my IPR. So this case, I didn't even delegate IPR to anyone. I did it myself because it was so critical that the IPR was done as good as possible, okay? Because I do find a lot of the newbie dentists who are starting aligners, they don't do IPR as well as we'd like them to. So my next refinement to the technician is, hey, keep all existing attachments because I want them all. Do expand my quadrants again, now this time by 2mm. So we're continuing the expansion. We've had no recession so far. Everything is going well. Let's do a tiny bit more expansion. Let's program more IPR. So this time we've done 0.3mm, 1.3 to 2.3, 3.3 to 4.3. And I want it all at stage 1, okay? Because I need to bring that canine down. So I need space. And then I'm basically saying maintain upper and lower incisor anteroposterior position, meaning don't forward them, don't retract them now. Keep midlines coincident. So everything you like, you got to tell them as well. Distalize quadrant 1 posterior teeth to move into molar class 1. I don't know why I said that. Maybe the class 1 had slipped a bit because she was class 1 to begin with. Extrude 1.3 by 3mm. Finish in class 1. Upper midline to stay same. Lower midline to match upper. Oh, I think because of the class 2 elastic, maybe her midline shifted a bit. Then I'm asking, not only you give me 0.3mm IPR on the top, now also give me additional 0.5mm IPR 1-2 mesial and distal, because 1-2 is really broad and 1-3 needed to come down. So look at the amount of IPR I've programmed here, 0.9 almost, okay? So I'm doing almost a millimeter of IPR now in my second set, having done 0.5 before. So this is going beyond biologic limits. This is going beyond biologic, what the papers say. Papers say the safest limit of IPR is 0.5mm per contact in the anterior region. However, those are studies on average Caucasian patients. When you look at a tooth that is relatively really wide, you've got to start doing IPR. Now, this IPR was done very differently. Even though I told the technician, do it all at stage 1, I did it progressively because you cannot cause sensitivity on this tooth. So this patient, we did 0.1, 0.2, 0.1. She kept coming back, kept coming back. That 1-2 was critical to get the IPR right. And until I wanted to make sure there's no sensitivity, so it went over a lot of appointments coming back just for IPR to make sure there's no sensitivity. We're still within enamel. Never delegated this. I did all this IPR myself because it was critical that we don't actually, cause any damage to the 1-2. Although she was open to bondings if that did happen, and veneer on the 1-2. So that we're now really going excess. Okay, so this is where you have to look at, right, can I push it? And everything, when I say I push it, I don't want any one of you to go in your practice and go replicate this, because this is a very delicate balance of constantly checking in on the patient, using dental monitoring, bringing them back in, checking their contacts, putting fluoride as you do IPR, because that's a lot of IPR she's had on the 1-2. It's almost like we're reshaping the 1-2. We're literally taking off a lot of enamel. Look at the amount of aligners in stage 2, even more than stage 1. So I'm now asking for 50 aligners here. Remember, no, the more aligners, the better. Slow down velocity. The more complex the movement, the more you got to ask for double the number of aligners than what Invisalign gives you. Again, see, 1, 1, 2, 1 are actually extruding, but I haven't actually put attachments on them. Why? Because they're also retracting. So I know that when they retract, they're going to come down naturally. So I've kind of bothered not to put on it. Plus, she has a beautiful smile and, she's a very vibrant person. I don't like attachments right at the front. They get a bit stained. I don't like it. So I just said, let's just go without attachments. So here we are. I'm not sure why I think I started to distalize there, thinking, look, even if I end up in a class 3 molar, maybe I'm going to use a bit of distalization here because I am struggling for space. This is a time where you could even extract. You could say, look, we're just not able to fit everything and get the objectives. Lucky she has no recession, right? Not lucky, actually, it's a genetic predisposition. She's unlikely to have too much recession. So we're just tucking back the upper quadrant 1, just 1/2 mil, just creating that extra 1/2 mil space just to bring that 1-3 down. 50 aligners, okay, a lot of aligners. Now, very compliant patients needed for that. We're almost like a couple of years in treatment or just under. So, this is just showing you what we're doing. It's just a lot of IPR. And if you think IPR is easy to do that much amount of IPR, you've got to keep looking on virtual appointments to see when is the right time to bring the patient in. She was very flexible, so that was great. Anytime we called her, said we want to see you IPR again, she just rocked up. She fit in with our schedule really nicely. So here we are. We're almost getting there, maintaining her class 1, midline almost there, resolving her crowding while she's retracted. You see her buccal shots. Look at her buccal shots. Her upper lower incisors are back. They're not worse than pre-treatment. Okay, if anything, they've been pulled back. Now, we can't change her profile. Okay, don't expect retraction of incisors can really change profile for someone with such thick protrusive lips. No way. Okay, unless you really extracted 4 premolars. Even then, you would only change it by 1 to 2 millimeter. Okay, so you cannot really change facial profiles that much with extraction. So anyhow, this one is going to, we're still lack of space, right? We're still lack of space. We're almost there now. I mean, it'd be crazy to extract now, right? It's crazy. We've done almost 5 millimeter of dental arch expansion. No recession, no recession. She's got a thick biotype, but I think we're at the limit for expansion. I think we can't really just keep expanding now. I think we got to still do more IPR. I really think there's no other way we can fit this. Luckily, she has no sensitivity on the 1-2-2-2, which had the most amount of IPR done to them. They're literally becoming more slimmer. They were really wide before. They're starting to even actually look proportionate now. So we're about 26 months in treatment, and that may be inaccurate because I think she finished at about 2, maybe it's right. So I say, look, we're so close to the finish line. She was happy to actually finish here. She's getting married. She said, I'm happy to finish. I can get a bonding down there. On the canine, I'm very happy. I don't really need to go on. I said, no, give me one more set. Let's keep going. So this is her dental monitoring, very compliant patient. I'm not sure why this is here, but just really, you can see the 1-3. Yeah, look at the 1-3. It's having a lot of unseat here. I think, sorry, I think Brittany put this here to show the unseat. So 1-3, obviously we know it's going to have unseat. It's the most difficult tooth to bring down. We expect a lot of unseats there. So we're going to ignore it. And I think these timelines are incorrect. Don't worry about the timelines, guys. So anyways, so we do a third revision. We are now asking for some new attachments. I think she was going to Nigeria or something. And then we're now getting a different attachment on 1-3. I said, I'm done with the horizontal. We're trying for like 2 sets. We've got to bring this down. So I actually put an oblique attachment. I really like the oblique attachments. I've done it for 2 or 3 cases where canines have been very difficult. And I really like it. And you're going to see it on the ClinCheck. So again, same thing, maintain overjet, overbite, maintain occlusion. I like the class 1. Continue extruding some of those teeth. I just wanted the posterior open bite starting to come. If you see here, we're getting a posterior open bite. So we need to start closing it. So we're saying, look, extrude all the premolars and molars because we want to start closing that a bit. Extrude 1-3, okay? And again, more IPR. We're doing more IPR again, 0.2 now. Okay, so now I'm asking for 26 aligners. We ended up with 33, although I told the technician I added more aligners. In a sec, you're going to see some more IPR. Okay, we've done close to 1 millimeter because I don't think I'd be that accurate. I reckon we've done a lot of IPR on that one too. But I've had a look. I've literally removed most of her attachments. Because I was very happy with the way she was. It was just 1-3. So we removed attachments and we said, look, let's just give you only one attachment. Now I want you to see this. This is the mesiodistal attachment, the oblique attachment that I have started using a lot with canines. And often when I'm doing a bit of a tip, so basically if the tooth is moving this way, I'm just going to draw it here. And I do find they work really well, a big one, conventional. Okay, so if I draw it here, yeah. So basically if your tooth is going to go, oh, guys, I'm just, need just give me a sec. Okay, so basically if the tooth is going to go here, right, I need it to tip. Where do I need it to tip? I need the root to tip this way, right? So you're going to place your oblique attachment this way. Okay, so when you got to go clockwise, I usually put it angulating towards mesial like that. Okay, if I had to do the opposite, I do it this way. Okay, the other way. So I use these oblique and they're quite nice and long, probably 4 or 5 millimeter across the whole tooth. And what it's doing, it's actually, the plastic puts a lot of pressure here and a lot more pressure here to start causing this clockwise rotation. So I changed my previous horizontal attachment because we were extruding, and that was a priority. Now we're fixing the rotation, but at the same time, I want a bit of extrusion as well. So I've kind of not got a vertical and I don't have an horizontal. I've got an oblique. So I've got something to do kind of both movements and a really big one. Okay, I didn't put a small one, a big one across the surface. So I do find some of my tricky cases where there've been a lot of movement, like my canine transposition case, you guys might have seen in my topic 17, I think, extraction with clear aligner lectures, where we moved the canine incredibly by 4 or 5 millimeters and then, transposition corrected. I used that attachment there as well after unsuccessfully using every attachment combination I can think of. And then I use this, and this is something that an orthodontist also in Dubai, actually, I was talking to him, he loves using them, and he showed me some cases. And I kind of tried them in my own patients, and I really like them. So if sometimes for these big canines, I'll go for these oblique attachments. Okay, so let's continue the plan. I think I have to stop this, okay. This is the occlusal. So basically all we're doing is just more IPR, more extrusion, more extrusion. It's lack of space. The 1-3 simply put needs more space, okay? So we've got zero recession, okay? So this is a patient where we're going biologically sensitively. Every revision we're checking, can we push it? Can we go next? Can we go to the next? From day one, I had no idea we'd get here. No way. In fact, I thought in 6 months, we're extracting her premolars. This is where we finished her a couple of days ago. She's ecstatic. I said to her that 1-3 needs to come down 0.2 millimeters more. Do you want to keep going? And she said, no, I'm getting married in March. I love this. I'm very happy. Finish me. I'm not worried about the mild posterior open bite. It's only 0.5 mil. Not at all concerned. Very common with aligners. Okay, so we've got her down here. Maybe she can, and she's really happy. Okay, so let's go from, this is her post-treatment scan. Okay, so I just kind of show scans sometimes. Some people like it better than photos. That's her before and after. You see the incredible amount of incisor retraction we got. I mean, that's mad without extraction. And so obviously a lot of it came from IPR and arch expansion. So if you look at her intraoral photo, you can see the amount of expansion that has been achieved here. When you look at the buccal shots, you can see how much we retracted her incisors. And while we're doing that, we even found the space to fit in all her teeth. So really crazy amount of work, but very diligent IPR, excessive IPR, but no sensitivity and no gingival recession. So for me, this was the right plan for her. If anything, her teeth are looking more proportionate in her smile. There is zero sensitivity. The IPR was done very carefully with a lot of fluoride varnishes at all times, done over 2.5 years. We gave her incredible amount of aligners. So 44 first set, 50 the next set. Then we've got another 30 or something the next set. So a lot of aligners, a very compliant patient. And I mean, to bring down that canine in an adult patient and tip it, it has to be a very compliant patient. To get there in 2.5 years, a highly compliant patient. I think she was 2.5 years. I don't think she was even 3. Anyways, before and after, overall, I think it's really a nice symmetric smile, no bondings, no veneers. And I do see the 1-3, you know, just a little bit, but look, it's me. She doesn't even notice it. I can just see that the cuspal tip could be just 0.1, 0.2 millimeter longer. But her dentist is fantastic. Her dentist can easily add a teeny tiny bit of bonding there, and she doesn't even care. So it's more that I'm going, oh, just add a bit of bonding and it'll just look nicer like the 2-3. And we finished here, and this is her before and after video, so you can see how we made the change. And this is all via dental monitoring. These videos are produced by dental monitoring as the patient scans their teeth. And yeah, that's the finish of the case. So I hope you guys like this case. Do you have any questions from this case? So I'm just looking at a lot of your comments. Okay. Is it still horizontal attachment for 1-3? I think I just answered that. We changed. Dr. V, my kids with crowding canal, this is so helpful. To be honest, the general dentist who was going to take on this case, I did a little, I said, no way, send this to me. There is no way this case should be treated by you. And I'm glad this dentist did send it to me, because I mean, this person was going to start treatment. I mean, I just think this is a very delicate case where it can be extraction. It could be at some point I might put braces on. So many things can go wrong. And I did not ever think that we'd get there. The only reason I thought let's try, because the patient was really easygoing with her expectations. On top of that, she had no recession. So every set we did, there's no recession. So we could keep going with a bit more expansion, okay? And no sensitivity on her enamels. So we knew that the enamel was so thick that we were able to reduce it to that degree. So why did you choose no exo? I think patient chose no exo. Okay, and to be honest, in African descent people, I actually like a bit of protrusiveness, because if I had extracted, I would have retracted them a bit too much. I actually think in hindsight, extraction, I would have got the same result with extraction too. I would have. it was more a patient preference. In fact, extraction would have been easier for me to go from day one than what we did, because at any point, I didn't know I could do more IPR. Every set I thought, can I do more IPR? I've already done 1.2 millimeter per side on that one too. Yeah, I've done incredible amount of IPR on that one too. That particular upper lateral incisor. And it was just really wide. And at any time she could have sensitivity and needed a veneer, right? So, and then it's like, I should have just extracted. If that had happened, I would have thought, why am I doing that? I should have just extracted and we would have got good result anyways. A lot of IPR. Someone's asking how much IPR. I just showed you multiple. If you look at it, maybe 2 had 1.5 almost millimeter per side. Okay. If I was really accurate, it's that much. And again, I would never, ever delegate this IPR to anyone, not even a dentist actually who works with me. I was like, I'm going to do this one. I remember telling that dentist, this IPR I have to do, okay? Because it was just, you just had to be very careful. Now, I have been a general dentist for 9 or 10 years. I've done a lot of restorative. I've done a lot of veneers. So I do have a very good grasp of how to do this really well. Okay, so would you prefer, yeah, very good question by Sunila. Would you prefer taking an intraoral periapical to assess enamel? Yeah, I didn't, but yeah, I mean, it would be very good, but it was really far back initially. Once it had come forward, possibly taking a periapical, you would have seen the thickness of the enamel and possibly every 2-3 months while you're doing IPR to see that you're within enamel. You know, I kind of saw it clinically by asking her, are there any symptoms, any sensitivity? And she kept saying no. And I mean, till the end, there's no sensitivity. So I'm thinking I'm within enamel. The OPG at the end kind of suggests that. I didn't think there was any issue there. So, but getting a periapical, routine periapical on that tooth, not a bad idea, because I went beyond biologic limits. But the biologic limit, as I said, is 0.5 millimeter per contact. So it's a fantastic case, guys. I hope you enjoyed it. Excellent questions. Excellent result. I'm ecstatic. The dentist ecstatic. The patient's ecstatic. And this is going to be one of them. One of the cases is going to go in my book. It's going to go on a YouTube channel. It's going to be one of those where I would even publish a case report on, because I just think it's incredible the amount of retraction we achieved with IPR alone. It goes to say a lot of studies on IPR on Caucasian patients. So we have a biologic limit of 0.5. But when you have an abnormally large tooth, especially if the enamel is thick, perhaps you can do more. Okay. Will the treatment be quicker with extraction? Actually, yes. If I had done extraction and braces, yes, I would have finished this in 2 years. Extraction is very fast with these type of cases, actually, with braces. With the aligners, no. So if you read, if you watch the topic 17, I think, lectures, extractions with clear aligners, the evidence shows extraction and clear aligners is a longer treatment time than extraction with fixed appliances. So with the aligners, no. Okay. All right. So I can't remember every conversation I had with her why we did non-extraction, but I think because she was very easygoing, she just wanted a small improvement. She didn't care. But obviously all these patients, they start off like that. And then, I mean, she was very easy, but they all changed the goal. So I know them. I've done thousands of cases like this. I know, and I always tell them, you're going to change the goal on me midway, because the moment you start seeing your teeth becoming nice and straight, you're going to say, let's keep going. So I never accept when patients say, I'm happy with just half a job. I don't agree with that, because I haven't seen them happy with half a job. So the fact she was easygoing, the fact that she just wanted a bit of improvement, a little bit of canine coming down, I thought, oh, let's do some IPR. Let's just see how it goes. And it just kept going really well for her. Okay, so guys, we're going to stop here.